Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about kidney stones. The likelihood of your developing a kidney stone in the course of your lifetime is about 1 in 10. If you live in the Middle East, it's about 1 in 4. Now remember that kidney stones have to start off as very small. If you drink enough liquid, you're going to wash the kidney out. You're going to prevent the precipitation. It's when you don't do that that problems begin. The stone can go from a teeny-weeny little thing, no bigger than a microscopic grain, and it slowly can increase until it gets to be about the size of a golf ball. As it gets larger, if it tries to pass, it might get lodged in a narrow area of the urinary tract, where the kidney joins with the ureter, or in the ureter halfway down to the bladder, where the ureter goes over some iliac vessels and is a little bit kinked or narrowed, or at the junction of the ureter and the bladder. Those are the common areas, with the junction of the ureter and the bladder being the most common. Well, in individuals, we have to worry, especially if they happen to have an anatomic abnormality. If there's some sort of a kink or some sort of a misdevelopment or maldevelopment of the urinary tract. We call urolithiasis any stone that forms anywhere in the urinary system. Nephrolithiasis, a stone in the kidney. Ureterolithiasis, a stone in the ureter, the tube that goes from the kidney to the bladder. Or cystolithiasis, when it develops in the bladder or comes from the kidney and sits in the bladder. The incidence of kidney stones appears to be increasing. They're more common typically in men than they are in women. Of course, of a lifetime, man has about a 20% chance of developing a kidney stone, a woman about 9% chance. The peak age somewhere between 20 and 50. In men, the peak is between 30 and 40. In women, there are actually two peaks, 35 and around 55 years of age. And actually, kidney stones are becoming so common in the pediatric age group because of obesity and because of excess salt that now some hospitals that never used to see any kidney stones in the pediatric population are now developing their own pediatric stone clinics. They're more common in Caucasians by a 3-fold factor compared to African Americans. If you have a kidney stone, the likelihood of recurrence in 5 years is about 50%. By 10 years, it's about 80%. And if you happen to have a recurrence of your kidney stone, then the likelihood of developing another recurrence within 3 years is anywhere between 40 and 80%. There are hundreds of different chemicals in the urinary system, mostly minerals. And sometimes those minerals precipitate out. They become supersaturated. And when they do, if there isn't enough liquid going through, if you have an inadequate fluid intake, or you're taking in too many of the minerals, then you are at risk. The kidney stones, of course, start off very small. They may pass asymptomatically. You don't even know you have them. They might get to the size of a pebble or even to the size of a golf ball. If they're less than about 0.2 of an inch in diameter, chances are they're going to pass by themselves. It might cause you some pain, but they'll be out 98% of the time in 4 weeks. If they're a little bit bigger, say between 0.2 and 0.4 of an inch, then they have a 50-50 chance of getting out. Chances are they're going to block the ureter, and chances are they're going to lead to severe pain. The real large ones that we call the Staghorn Calculi are in the kidney, and they're not coming out no matter what. Stones can either be smooth or jagged in appearance. They can be yellow or brown or black. They can be off-white. They can be pink or yellow. They tend to have calcium and oxalate and sometimes phosphate, or they might be uric acid stones, a couple other kinds of stones. The calcium oxalate stones, 80% of all. Calcium phosphate stones, 5 to 10%. But the calcium oxalate stones form on a little grain of calcium phosphate. Calcium phosphate comes first, and then you deposit on top of it the calcium oxalate. Uric acid stones, oftentimes people think of as being associated with gout, but they can come on without gout. That's uric acid, 5 to 10% of the time, the stones. And then we have the Staghorn calculi that develop and stay in the collecting system of the kidney. Those are a little different kind. They're up to 5 or 10% of all of the stones. They're a dirty white color. Well, the calcium oxalate stones can change into these Staghorn calculi or the Struvite calculi if they happen to be infected. Or the calcium oxalate stone can form into a calcium phosphate stone if we increase the pH of the urine too much. Most of the time, however, remember, it's calcium oxalate. Those are the stones that form on a little grain of phosphate, and it's because of a supersaturation in the urine. It's independent of the urine pH as opposed to other kind of stones. So we get that initial calcium phosphate, then we start putting out the calcium oxalate on top of it. And there's only one substance that we have that can reduce the formation of kidney stones, at least at the present time that we know of, and it's called citric acid. That reduces the calcium oxalate stones. Now, there's a different kind of stone, the uric acid stone. Uric acid stone is softer than other kind of stones. It doesn't have any calcium in it. It forms in an acid urine. Acid urine can't keep too much uric acid solubilized, but an alkaline urine can. So in people who have uric acid stones, we want to alter the pH of the urine. That's something that we can simply do, and by doing it, we can eliminate a lot of problems. If you have a uric acid stone, you've got to be a little bit careful of too much protein in your diet. If you have gout, that ought to be treated. Struvite stones, those big stones that form in the kidney, they tend to be more often in women than in men, unlike most of the kidney stones. They're less common. They seem to be associated with bacterial infection, bacteria that can break down the urea into a form of ammonium, and that ammonium joins with some magnesium and some phosphate, and then it lodges up in the kidney, sometimes called Staghorn calculi. Well, the environment has a lot to do with whether you're going to get a kidney stone. So if it's the summertime and you happen to live in the desert and you perspire a lot, that means you're probably going to become somewhat dehydrated. Then you're going to be at risk. The hot weather, the heavy perspiration, if you're out exercising, some kind of conditions, maybe if you have overactive parathyroid gland, or if you're diabetic, or you have the metabolic syndrome, or you have gout and you have too much uric acid floating around, you're at greater risk. Also, if you're not taking enough fluid in, if you're exercising too much, if you're taking too much animal protein in, or protein powder, or you have excess sugar that you're consuming, especially the fructose or the high fructose corn syrup. Now, interestingly enough, if you take a calcium supplement, you're at higher risk for developing a kidney stone. If you have a diet low in natural food-borne calcium, you're also at greater risk. If you have too much salt in your diet, you're at risk because the sodium carries with it some of the calcium. And if you have low levels of phytate that you would get in grain or beans or whole wheat, well, that puts you at greater risk. If on a genetic basis, you seem to just have a lot of calcium in the urine or oxalic acid in the urine, or you don't have enough citrate in the urine, you're at greater risk. Certainly people who have infection in the urinary tract are at greater risk. And then there was a study that was done at Harvard to sort of highlight some of the things we're talking about. They looked at 45,000 men who had no history of kidney stones. They followed them for 4 years, and 500 of those men developed kidney stones. And interestingly enough, the people who consumed the most calcium from food had the lowest incidence, had a 50% reduction in the incidence of kidney stones. So it's the supplements that get you in trouble, not the food calcium that gets you in trouble. So the more milk and cheese and yogurt and broccoli you have, all of those bind the oxalic acid or the oxalate in the intestine and prevent the oxalic acid from being absorbed. That's very important. The calcium supplements, they don't do that. The Women's Health Initiative in the 1990s, they demonstrated quite clearly that women who took supplements So they wanted to protect their bones. So they took 1,000 milligrams of calcium plus 400 international units of vitamin D, and they had about a 20% increase in their risk of kidney stones. No problem with the dietary calcium, but again, it's the supplement that seems to get you in trouble because the supplement won't bind the oxalic acid in the urine. Just to remind you, excess salt, that's going to pull the calcium with it into the urine, and our diets contain 2 or 3 times as much sodium as they should. A diet high in oxalic acid in some people is going to get you in trouble, so green leafy vegetables and tea and chocolate might cause significant problem. High animal protein intake makes your body somewhat more acidic. If it makes it more acidic, it's going to dissolve the bone somewhat. It will dissolve the bone. More calcium in the urine, obviously a significant problem, and it also tends to decrease the amount of citric acid in the urine. Well, we have to pay attention to the pH, the acidity and the alkalinity of the urine, because that can modulate. If we get a higher alkalinity in the urine, then we're going to dissolve uric acid stones. But if we make the urine too alkaline, we also are going to have a tendency to deposit the calcium phosphate kind of stone. Well, your body has some inhibiting substances that prevent the deposition of stones. That's the citric acid or the citrate. There are some other substances that the body manufactures that we don't have as pill form yet. Well, if you consume more potassium, the potassium seems to increase the citrate in the urine, so that's good. And if you increase the magnesium in your diet, that tends to decrease the likelihood of stones. The symptoms, you might not have any. Might be totally pain-free. Might have a vague stomachache kind of problem that doesn't go away. Or you could have the severe pain on either side of your lower back, below the ribs. It can radiate to your lower abdomen or your groin or your testicles, if you're a man. Can come in waves. Last about 45 minutes and then seems to disappear. Then can come back again. That has to do with the peristalsis, the rhythmic contraction of the ureter. The pain can become steady and it can become unbearable. It can persist for hours on end. It can end as abruptly as it begins if the kidney stone starts to pass, unblocks the urinary tract. If you have blockage, it can increase the pressure in the kidney and that swells with the fluid and then that can cause pain. That's what they call water on the kidney. And if it does, the kidney is going to be reduced in function, and that can lead to permanent damage if the situation is prolonged. Well, the pain of renal colic can be as bad as any kind of pain we know, and that has to do with the obstruction and the dilation and the irritation of the nerves, and it makes a person restless, and you keep trying to find a position where you're comfortable, and it's a futile attempt because you can't. As opposed to, let's say, diverticulitis or appendicitis, where you don't move at all. You find that movement causes increased pain. So that's how we can sort of differentiate whether the kidney's at fault or it's some intestinal problem. Or sometimes bleeding is the issue. It could be microscopic bleeding, or it could be macroscopic bleeding, bleeding that's visible to the naked eye. So it could turn the urine either pink or red or brown. And if there's no pain, actually, might be the only sign of a urinary tract infection. And sometimes the symptoms can be non-specific, especially if you have an infection. You could have nausea or vomiting or fever. You could have the persistent need to urinate. Only a little bit comes out. And as I mentioned before, in the pediatric population that we don't typically consider prone to develop kidney stones, they are developing them with increased frequency, especially because of the increased weight and the poor diet, with all of the sodium. Well, there's some other things that might be included in the differential. When you have a terrible abdominal pain, it might be appendicitis, or it might be a bowel obstruction, or it might be gallbladder disease, or an ovarian abscess, or a ruptured ovarian cyst, or even pelvic inflammatory disease, or pyelonephritis, infection of the kidney. Or it might be an abdominal aortic aneurysm. Well, we can do some tests on the urine itself. We can do some blood tests, see if there's anything afoul. But we really would like ultimately to do a urine test, a 24-hour urine collection. We'd like to do it twice because there's some variation day to day. We'd like to wait about 4 to 6 weeks after you have the stone, and then we'd like to test the urine, find out how much calcium, how much phosphate, how much oxalate, how much citric acid, how much uric acid is in there, because that can help guide us to hopefully prevent recurrent stones. Yes, we can prevent recurrences. So to test to see if you really have a kidney stone, we might do a CAT scan, we might do an ultrasound examination, we might do a simple flat plate of the abdomen, just a standard x-ray. Well, the stones have different densities. So for instance, a uric acid stone doesn't have any calcium. It's not going to show up on an x-ray. Well, oxalic acid is very important in kidney stones. People don't realize that. Most people think it's just the calcium, but it's not just the calcium. Actually, the oxalic acid is a 15-time greater promoter of kidney stones, of calcium oxalate stones, than the calcium. So the oxalic acid is naturally in a lot of foods. It's present in asparagus and celery and nuts and almonds and cashews and in soy products and in cheese and in grains. It's in oatmeal and whole wheat, and actually can be manufactured in the liver. So most men who have stones seem to have an increased amount of calcium in the urine. And that fault is not with the kidney. The fault is with the intestinal tract. They tend to absorb too much calcium. And when they absorb too much calcium, then of course, once it's metabolized, it goes out in the urine. So it would sound like restricting the calcium in your diet should make sense, especially if you have what we call hypercalciuria, too much calcium in the urine. But the calcium in your diet, in the food, not a supplement, if it's in the food, remember, it's going to bind the oxalic acid, and since that's the big problem, that's very important. So you want the calcium in your food. You don't want a supplement. Don't take the supplement. Take the food with the calcium. And that's ultimately going to bind the oxalic acid and get it out without causing a problem. Citric acid. So citrate. Some people have low citrate in the urine. Citrate prevents the crystallization or the precipitation. So it's important you have the citric acid. If you have less than 320 milligrams a day, that's low level. Cause kidney stones up to about 2/3 of the people. So citrate decreases the supersaturation of the calcium salt. It forms soluble complexes with calcium, gets it out before it harms you. Well, if you have a kidney stone, what do? You drink a lot of liquid. You drink an awful lot of liquid, 2 or 3 quarts a day. And you keep doing that forever, basically, because you want to make sure that you're not going to get a recurrence of your kidney stone. And if you have too much pain, you can't hold anything down, then you go to the hospital and get it intravenously. You take some pain medicine. Now, different kind of pain medicines. None works really great. Oftentimes people are given opioids. That's an iffy issue nowadays. Antispasmodics don't seem to help. You want to drink enough liquid so that you get up at least 1 time a night. And if you do that, if you have those 2 to 3 quarts a day, that's by itself reduces the likelihood of recurrence by about 40%. Most of the people don't need to go to the hospital, sometimes to the emergency room, but not in the hospital. If the kidney stone is small, less than a pencil eraser, less than 2/10 of an inch, probably it's going to pass by itself. If it's between 0.2 and 0.4 inches in diameter, well, we're going to wait around as long as the pain isn't too bad, as long as you don't have a urinary tract infection, as long as there's no damage to the kidney, as long as there's not persistent profuse bleeding. We can wait it out because 50-50 chance it's going to pass and you're not going to need any kind of medical intervention. If the stone happens to be in the kidney and you're not having any kind of symptoms, there's no obstruction, there's no infection, there's no serious bleeding, there's no bleeding at all, or there's no persistent pain, then we can just watch it. We don't have to do anything. And again, if it's in the ureter and it's not causing any fever or infection or renal failure, we can sit tight for a while. The medicines, well, pain medicine, we want to make the acid, make the urine less acidic. If you happen to have a uric acid stone, we know that we can use an alpha blocker, medicine like tamsulosin or Flomax, relaxes the smooth muscle cells of the ureter so that hopefully the stone will pass more quickly. There's some question about whether it does that or not, but that certainly is a legitimate thing to do. Calcium blockers like nifedipine may do the same thing. In those people who have uric acid stones, again, getting back to the importance of finding out what kind of stone you have and doing those tests, if you have a uric acid stone, we can alkalinize the urine, make the pH go in excess of 6.5. And that by itself might cause the stone to dissolve. These stones, the uric acid stones, are softer than the calcium stones. And maybe by giving somebody some sodium bicarbonate or some potassium or magnesium citrate or bicitra, maybe we can dissolve the stones without any kind of intervention. If we need an intervention, there's shockwave lithotripsy, where you go into the facility and they blast it with high energy ultrasound waves. Well, that's good, except if you're too heavy, that means that the distance between the surface of your skin and the kidney stone is going to be too far, so it might not work. And when you're done with a session of shockwave lithotripsy, you feel a little bit beat up. You have some bruising and some discomfort, and they only break up the stone. They don't make the stone pass, so the stone might still get lodged, or fragments of the stone might get lodged. And not all stones are equal as far as their susceptibility to improvement with shockwave lithotripsy. So then we have ureteroscopy. We pass a tube through the urethra into the bladder, and then we pass another kind of tube through there, so we can either with a basket grab the stone if it's lodged at the junction of the ureter, the bladder, or maybe even go up a little bit further and pull the stone out, or we can blast the stone right from there. And that seems to work a heck of a lot better, but it's associated with some more complications than the shockwave lithotripsy. Seems to be better if you happen to be obese, or if you're pregnant, or if there's a bleeding issue. And then in some individuals, we can actually go in through the skin right into the kidney itself, into the pelvis of the kidney, and pull out the stone. Sort of the same way that we did from down below, but we can do it from up above, if the stone happens to be very large. Well, then the issue is prevention. So once we get over the acute hurdle, you got to continue drinking a lot of liquid. You want to make the urine very dilute. You want it so it's light yellow or clear. And you have to remember, limit the amount of sodium that you're consuming. 1,500 milligrams is a good amount for a total day. Look and see some of the foods that you're eating, how much sodium they contain. Well, colas are okay, but unfortunately, since they contain phosphate, they might not be okay. So if you're going to drink, yes, you can have carbonated beverages, but something like a 7-Up might be better. And certainly you want a diet beverage, because you don't want the fructose or the high fructose corn syrup. By the way, grapefruit juice and apple juice aren't very good for you either. So avoid excessive animal protein. Animal protein, meat, chicken, fish, that's going to make an increased acidic load. Acidic load is going to dissolve some of the bone. That means calcium is going to go to the kidney. We don't want that. So the more acid you get, the more calcium in the urine, uric acid in the urine, and the decrease in the citrate in the urine. You want to have more non-animal protein sources, the legumes, the peas, the lentils, the nuts, sunflower seeds, and the tofu. They're less likely to cause problems. You want to decrease the amount of salt. Decrease it to less than that 1,500 milligrams. You want to consume a lot of liquid. You want to make sure that you're dilute. Your urine is very dilute. As a substitute, you could use Mrs. Dash's. That's got very low, no sodium. You should avoid potato chips and French fries and canned soups and breads and packaged meat. We know that obese people have a higher tendency to develop kidney stones, so we want to consider a diet, but not a crash diet, and probably not a high protein diet. And we want to decrease the foods that are rich in oxalic acid, if that happens to be an issue in your particular case that we would learn about from analysis of the urine. So we would like to cut down on the beets and the spinach and the sweet potatoes and the nuts and the chocolate and the soy products for those individuals. We could use a thiazide diuretic if the issue is calcium, because the thiazide diuretic that you might take for blood pressure control, hydrochlorothiazide or something like that, well, that decreases the amount of calcium in the urine. You also have to make sure that you reduce the amount of sodium you're consuming. That's always important. You can increase the amount of potassium in your diet. If you increase the amount of potassium in your diet, that increases the potassium citrate, but the citric acid, lemon lime juice, that's a good way to start. Well, in addition, we know that some people who have calcium oxalate stones are going to get worse if they consume too much vitamin C, because vitamin C increases the amount of oxalic acid produced by the body. So you want to be careful of that. You don't want to be one of these people who is just taking an awful lot of vitamin C substitutes or vitamin C tablets or vitamin C supplements. If you happen to have a calcium phosphate stone, we don't want to get more potassium citrate. If we get too much potassium citrate and you happen to have a calcium phosphate stone, that increase in the pH of the urine might actually make matters worse. And then, if the issue happens to be a uric acid stone, maybe you have gout, maybe that needs to be treated with some allopurinol. Well, in uric acid stones, we want foods that are rich in alkali so that the pH of the urine goes up. Here we would like the potassium citrate and the sodium bicarbonate. We would like to increase the urine pH considerably, and that means we want to stay away from foods that have a tendency to make the urine acidic, like animal proteins. So that's kind of a whirlwind tour of kidney stones. Remember, they're extraordinarily common and they're becoming even more common, but the most important thing people need to realize is just because you have one kidney stone doesn't mean you have to develop another. There are things that we can do to help prevent them, and you ought to take advantage of that. Anyway, thanks for watching. I'm Dr. Ken Landau.